Thank you very much, and thank you kindly for the invitation to speak about a topic that has been of interest for many years. There are my disclosures related to this topic. What we see here is a survey from now probably about 17 years ago, or at least a survey that was published 17 years ago by the National Registry for Myocardial Infarction, a large U.S. administrative database of patients with acute myocardial infarction. And what you see is, when we focus on the cardiogenic shock patients, it's a high mortality. Now, this is the kind of high mortality that we see in all-comer shock patients. The kind of mortalities you see in interventional studies tend to be in the 40 to 45% range in coming out of cath labs, out of interventional programs, and out of studies such as shock IBP2. But these are highly selected patients. These are not all-comer patients. It's also important to remember that, of course, this is the majority of the patients who present with acute myocardial infarction. And these are the kind of mortalities on the left of 6.2% that we see in most randomized trials of therapies in STEMI. Reperfusion, various medications. So really we're testing these medications on the lowest risk STEMI patients, not on the higher risk patients. It's also important to remember that in this particular database, at least, and this was a large group of patients, that as soon as you develop heart failure, either whether you present with heart failure or whether you develop it during admission, your mortality is considerably higher. So a third of patients who develop heart failure after admission actually didn't make it out of hospital, and a quarter or a fifth of the patients who developed heart failure on presentation, already had it on presentation, actually didn't make it out of hospital. And we can easily tip patients who have heart failure, who are precarious, into that cardiogenic shock range. So we also have to be careful with the therapies that we use, especially in the first day, second day, when the patients are potentially not very stable. This is a little bit of Ontario data, and I bet it's not that dissimilar to other regions in Canada, where we looked at patients with cardiogenic shock and what the trends were in revascularization and transfer of patients out of non-cathing and non-interventional hospitals, which is still the majority of hospitals, I'm sure in Quebec, and certainly in Ontario, and certainly elsewhere in Canada, to interventional centers. So it was actually quite eye-opening. Over the time period, so this was we had 3 time periods, 92 to 99, which is really prior to the guideline that stated that emergency revascularization is a class 1 indication for cardiogenic shock. Prior to that, we just had registries, and some people did it, some people didn't. Patients were admitted to CCUs and essentially did this, circled the drain on vasopressors, inotropes, balloon pump perhaps intubated, ventilated, but that's all we had. Mortalities were in the 80-90% range. So the shock trial, which was published in '98, clearly showed actually a 13% absolute reduction in mortality at 6 months, 1 year, and even 10 years in patients who were emergently revascularized. Now, we talked about early revascularization. Early revascularization in shock is it's considerably different than early revascularization in STEMI, what we could consider the golden hour. Remember that patients who were eligible for the shock trial were patients up to 48 hours post-onset of MI, up to 12 hours post-onset of shock. So in fact, those who were randomized to early revascularization had a window of up to 18 hours after diagnosis of shock before they were revascularized, and those with late up to 54. So that's the kind of time frame we have to remember, that it's not fatalistic and it's not at all useless if the patient is a little bit beyond or had their infarct yesterday or even 2 days ago, as long as a shock occurred within today, for example. So those are important things to remember. So what we see here is that over these time periods, and the second time period, by the way, is 2004. That's after we had published some data that suggested that elderly patients aged 75 or older also at least had an association with better outcome. Another registry showed that as well. if they had revascularization versus those who didn't, highly selected, obviously, population. So in 2004, the second recommendation for shock was as a class 2 recommendation for patients 75 years or older. So we looked at mortalities, and the last period was our period when both recommendations were made, 2004, 2008. These are the data we had. So as you can see, the one-year mortality decreased, both crude mortality and adjusted mortality in these time periods. But let's look what happened to revascularization patterns. So these are revascularization rates of patients in revascularization-capable hospitals and not revascularization-capable hospitals in the white or not filled in. And it's horrendous, actually. Patients in non-revasc capable hospitals are simply not transferred, not revascularized, not transferred. The majority of them are not. So that I think is upon all of us, really, to educate physicians in peripheral hospitals that it's not fatalistic, it's not futile, if you wish, to transfer patients for revascularization. I think that still happens, even 9 years later today. So guideline number 1, little blip, and certainly a significant blip in revasc-capable hospitals. And guideline number 2, and we also looked at this by age, and certainly the patients who were 75 or older had a very low likelihood of being transferred from a non-revascularization site to a revascularization hospital. Overall, the mortality dropped significantly in revascularization capable hospitals, but not in not revascularization capable hospitals. So this is basically I think a public health concern and an education concern that we have not addressed yet. And I think that needs to be addressed as a major, major problem. Now, cardiogenic shock is not a condition of pure acute LV dysfunction. So the mean ejection fraction in the shock trial, for example, was 30%. In TRIUMPH, a trial of non-selective NO synthase inhibition, was 27%. And in SHOCK IBP2, the trial that proved, quote unquote, that the balloon pump is useless in cardiogenic shock, and we can discuss that later when we discuss mechanical assist, the mean ejection fraction was actually 35%. Whereas if you look at trials of protection in high-risk PCI, so mechanical protection, BESIS 1, 23.6%, PROTECT 2, 23.4%. So this is not a problem of LV dysfunction. It is, as was already pointed out, very often an inflammatory condition. So my slide of this is, it's still going the wrong way, but anyways, not a big deal. So we have, in addition to the spiral of LV dysfunction, increased hypoxemia, ischemia, progressive dysfunction, we also have the systemic inflammatory response with increase in inflammatory cytokines, increase in inducible nitric oxide synthase, or INOS, which produces this overproduction of nitric oxide peroxynitrites, which contributes to vasodilatation rather than vasoconstriction, except perhaps in microcirculation, and that certainly needs to be studied more. And then, of course, there is the feedback of decreasing coronary perfusion, systemic perfusion, as well as the direct toxic effects of these peroxynitrites and free radicals on myocardial function itself. Not vasoconstriction. We hardly ever see vasoconstriction if we do Swan-Ganz monitoring, calculation of SVRs in patients who might be on 2 or 3 vasopressors, in fact. So the principles then are to maintain adequate cardiac output. Does that mean we go for a cardiac output of our index of 2.2, which is above the diagnosis of shock? No, it's whatever it takes to provide adequate organ function. That could be with inotropes, vasopressors, as much as they are deleterious in many respects, but it's at this point all we have. It may be mechanical support, and we can argue which mechanical support. None thus far has been shown in any randomized trial to actually be of benefit compared to the other or compared to nothing. And also the timing of mechanical support. All I'll say at this point is that all the trials to date of mechanical support, whether it be balloon pump versus nothing or LVAD, Impella, or tandem heart versus balloon pump. The majority of cases, the device was deployed after the PCI, not before the PCI. So that, to me, is a major problem. We need to correct whatever metabolic disturbances there are. Maintain oxygenation, ventilation. This sometimes we forget. We need to intubate patients who are struggling. They'll have a better outcome. Of course, we must rule out mechanical causes. Early vascularization we already discussed and what that actually entails. That's not like the 0 to 6 hours in STEMI that preserves LV function. That CABG is as good as PCI, if not better. That the mortality in the shock trial with CABG was 24%, the lowest in the trial of any of the patients. Of course, these patients were somewhat selected by the surgeons, but nonetheless, a very low mortality rate. So let's look at what we do with pharmacology after all that. The basis of our therapy are the catecholamine derivatives. So the first, this is the endogenous pathway and the synthetic catecholamines. We, of course, utilize in shock primarily these three, as well as dobutamine, the synthetic agent, dopamine, norepinephrine, epinephrine, just a little bit at what they actually do. Dopamine at low doses was said to have a renal sparing effect. That, I think, has been disproven. It is not true. It doesn't exist. At medium doses, and it may have an inotropic effect, certainly for the, if you wish, the decompensated heart failure patients, there's definitely an inotropic effect of dopamine at those doses. At 3 to 10, it is primarily an inotropic effect, while at higher doses, the alpha-adrenergic or pressor effect tends to predominate. Now, at all of these doses, the dopamine will have deleterious effects at the higher doses in particular, as will norepinephrine, which is primarily a pressor agent, with very modest inotropic activity. With prolonged infusions, it will have direct toxic effects on cardiac myocytes, inducing apoptosis. Epinephrine we use as well. It's more used by anesthetists than it is by us in cardiogenic shock, but certainly in extremis we do utilize it. It has all the effects, beta 1, beta 2, alpha 1, depending on what concentration, what dose you use. Beta at lower doses, the pressor alpha 1 effects at higher doses. It too, at high and prolonged doses, will damage the arterial walls and contribute to myocyte apoptosis. I'll talk about vasopressin because it's not a catecholamine derivative, of course. It's produced in the pituitary gland. We certainly use it secondary to increase in plasma osmolality. It's produced in all of these organs secondary to stressor events or stressor agents, if you wish. In the heart, secondary to increase in wall stress, and secondary to increase in catecholamine secretion in the adrenal gland. So it has various effects. The ones that I'll point out very briefly, it has neutral or inhibitory effect on cardiac output. It reduces nitric oxide production with what we talked about that may actually be useful. It will reverse adrenergic receptor downregulation, and its pressor effects are relatively preserved during hypoxia and acidosis. So relatively important. Phosphodiesterase inhibitors, I will not dwell a lot on this particular slide. The one that we have, of course, is the intravenous agent milrinone. Enoxaparin was an oral agent which was found to actually increase mortality. There's no data for milrinone in shock. I do not recommend using it. I don't think any guidelines recommend using it, mostly because it actually exerts its effect at the expense of oxygen consumption. It also has been shown to increase death rate compared to placebo in ischemic heart disease patients, not in shock necessarily. It has proarrhythmic potential. It's very vasodilatory, so in shock that's not necessarily going to be particularly useful. There are no adequate randomized trials data, and I would not recommend using it. What do we use then first? So before, we used to use dopamine as first-line therapy. With this, the SOAP2 trial, which was a trial in all-comer shock patients, septic, hypovolemic, cardiogenic, but with these groups being pre-specified and then subsequently analyzed separately, they showed a strong trend towards benefit with norepinephrine. And with the pre-specified subgroup for cardiogenic shock, that's where the benefit was actually found. So it's the best data we're going to have. We've certainly switched to norepinephrine as the first-line agent. With second-line agent dopamine, if we still a second pressor, or vasopressin. And finally, if we have very high filling pressures, then the use of dopamine can be helpful. Phosphodiesterase inhibitors and levosimendan, because it's not available in Canada, we don't really know whether it improves outcomes or not. Levosimendan is used in Europe quite a bit. RV shock, usually treated with dobutamine as first-line therapy. Now, diuresis, acute renal failure, of course, is very common in cardiogenic shock. Loop diuretics are often used. Once you have renal dysfunction, established renal dysfunction, loop diuretics will not improve this. They will only increase adverse effects. As you can see in this particular meta-analysis done in Britain a number of years ago, whereas they do nothing actually to improve the acute renal dysfunction. So we need to move to renal replacement sooner. This is a study, again, in critically ill patients that was just reported recently in 2016, over 200 patients randomized trial, where they instituted renal replacement therapy, CVVHD, within 8 hours of at least 12 hours of less than 30, I believe it was 0.3 cc's per kilo per hour, or a doubling of creatinine versus more than 12 hours and tripling of the creatinine. And those who had renal replacement earlier can see had a marked improvement in mortality. So this is something we do have to think about and not delay. We sometimes tend to delay renal replacement a little too long, I think. Metabolic acidosis, only to say that we all know that bicarb actually doesn't improve outcome. It makes us feel better because the pHs are higher, but really we need to solve the problem that is causing the acidosis, not give sodium bicarb. Hyperglycemia I'll focus on a little bit, only to say that not only does hyperglycemia increase lactate production, not only is it pro-inflammatory, and it increases oxidative stress. Treatment of hyperglycemia or insulin therapy in myocardial infarction has been shown to reduce both C-reactive protein and reduce plasmid activator inhibitor. There was, of course, a decade ago or so, a decade and a half, a strategy called GIK, which people thought that insulin administration would be useful. Of course, to give insulin to most patients with STEMI, you had to give them glucose, otherwise they go hypoglycemic. And to do all of this, you had to give them potassium. And to do all of this, you had to use large volumes. So these patients actually were fluid overloaded and became hyperglycemic and actually didn't have better outcome. So several smaller studies suggested this, small studies up to 800. But when this study, led by, I believe, Shamir Mehta was the lead author of this, showed that actually there was absolutely no benefit to this. Nonetheless, there is circumstantial evidence that insulin therapy is beneficial. It's something that's pretty quiet when we're treating a shock patient, resuscitating a shock patient. It's not something we think about. We often have glucose levels of 20, 15, even more, and it just kind of goes by as the nurse says, oh, glucose 20, oh, all right, let's just give more bicarb. For that acidosis that we're also seeing at the same time. It is important. This is a multivariate or a logistic regression that showed that glucose serum levels actually have a marked significant effect, independent effect on mortality. From severe sepsis trials, we know that we don't need to have intensive insulin therapy, only moderate therapy. In this particular trial, achieving a level of around 8.4 millimoles per liter versus going for 4 to 6 millimoles per liter actually was not inferior, was as good with low risk of hypoglycemic, symptomatic hypoglycemic episodes. Other pharmacotherapy, when treating dysrhythmias, avoid beta blockers, calcium blockers, obviously, because they'll further compromise myocardial infarction. avoid propofol when sedating patients, either for intubation or for cardioversion. It will cause profound hypotension, profoundly exacerbated. It has a delayed onset of action, so whoever is administering it will want to administer more because it hasn't been particularly effective. So fentanyl, benzodiazepine, or ketamine, midazolam are very effective agents in this regard. For intubation, actually, our good cardiac anesthetists can do with local anesthetic and don't actually need systemic sedation for this. I'll skip reperfusion therapy and, of course, early revascularization, which I had already discussed, and novel therapies because we're essentially out of time. We are in need of novel therapies because what we're doing right now isn't really working yet. At best, we have mortalities of 40%, but really in all comers, as you can see, it's 60, 70% still. So there's one that we tried, and we tried to reduce nitric oxide production through non-selective inhibition of nitric oxide synthase based on a very small study done in Israel where 15 patients in each arm were randomized to L-NAME and versus placebo, showing this amazing improvement in outcome in these shock patients. However, when we then did a pilot study as well as a large randomized trial, we showed absolutely no benefit of this. So clearly we're still struggling, we're flailing away, and hopefully we'll find the magic bullet. We haven't found it yet. Where do we go from here? Metabolic intervention, phospholipase inhibition's been tried, perhaps INOS inhibition, but I don't think anybody's going to do that trial anymore. Cell therapy is too slow in this particular setting. LV, RV assist devices, we still have to fine-tune that particular scenario. So for now, norepinephrine is a preferred first-line pressor. We must remember to treat hyperglycemia. It will have a profound effect on outcome. Dialyze early. If you're in a non-interventional center, transfer early. This is not a medical emergency. This is an interventional emergency. Okay? Cardiogenic shock is a SIRS phenomenon. We found that non-selective NOS inhibition did not improve outcome, and other strategies must be explored. Thank you.
Thank you very much.